again, thinking about obviously you as yourself as a therapist, what should they be doing within the golf swing, and what will you be looking for from the hips to be able to again have a healthy golf swing, but also a healthy body and hips and lower back themselves?
So generally, what you'll find is that, so we go again, right-handed golfer. So their left hip should have good internal rotation. The pros will have upwards of kind of 60 degrees of internal rotation, some of them. So that's quite a lot. I don't necessarily find that in the amateurs, but it's something I try and get them to attack, either with their self homework that they do, or the treatment modalities, the hands-on work, the needling, the ART, all those things just to help mobilize the hip and certainly give them some joint work to do at home. So left hip internal rotation, and then for the right, I need that to have external rotation. Because if through impact they don't have that left internal rotation and hip mobility, external rotation on that side, what will happen is they've only one place to go in the golf swing from impact. They're going to start to reverse spine angle. And there's only so many golf swings that can happen. It's going to start to overload the lower back. So you will get very similar pain patterns in the neck as you will get in the lower back, except for the lower back, it's generally going to be right-sided back pain. So right facet, iliolumbar ligament. The quadratus lumborum on the QL is on the left hand, or the right-hand side is put under a lot of strain because it's trying to stop people having to do that. So I find that a lot of back issues for golfers will clear up once they clear the hips. Right. And if they have good rotational control. So for obviously we've just covered the neck side of it and back. I often, like, if they can, rolling patterns for me from obviously SFMA, FMS, they're very important. So if they can get good rotational control and development through there, it'll really help. But they need to have good prerequisite movement. So if I screen a golfer for back pain, it's straight to the hips. Because if it doesn't hurt the back, poor hip mobility is going to hurt the knees and maybe down the chain.
With regards, sort of following on from that, any common injuries you come across? You've obviously mentioned one with regards to the QL, but are there any other that you tend to find? So
same again as for the neck, it'll be facet, disc. You don't see it, well, it depends. I tend to have, the work that I do with the professionals, I tend to do so much work through their hips, it tended to take a lot of load off the lower back. But depending on the player's swing, it'll load either the neck or lower back a little harder. But you will see, maybe in the amateur, see more lower disc problems, facet issues, so the joint gets overloaded. And then what I've seen with the Celtic population, a lot of the UK and Ireland, and then anyone that has Celtic heritage is and something that Stuart McGillen and a few other people, Eric Cressy I think was talking about, or we're talking about the actual hip architecture that we have. The Celtic population tends not to have the most mobile of hips, so they might have retroversion or introversion so the hips mightn't actually be in a good genetic position, so that may well lead to problems. So on top of that, what's going to happen is the labrum, which is a covering like around the cartilage in the hip, that can start to wear. So you begin to imagine if somebody didn't have good lead hip internal rotation and they keep loading into that joint, and it's going to start to deteriorate. And I think that's why we're seeing increasing rates of labral surgeries. Although I was reading an article about Australia, and they're tending not to operate on the labrums as much now because they're not. Even though they're finding them probably with better imaging and athletes are sent for imaging quicker, it's not leading to better results.
And are there any, again, with those types of injuries, maybe mention about maybe they couldn't do a great deal about the labrum, but are there any sort of self-treatments, QL, anything for the labrum that they can do themselves, just not necessarily to sort of rehab it, but just keep it healthy in any way?
So some of the things I like to give patients, there's a couple of things. I would give them, dynamic neurostabilization's got some good hip mobility. So if you look up like side-lying 5 months position, which 5 months is related to the baby's development, but side-lying position, and it's called a DNS 5 months sideline, like a pelvic and hip opening. You can mobilize the pelvis over the hip. So I find even in arthritic hips, it's quite comfortable to do. So at least you can maintain the range of motion, and I quite like Andrew Ospina's functional range conditioning for around there. So look up quadruped hip CARs, so they're controlled articular rotations, and if they're done every day, it can really help the labrum. And I think if somebody's got labral issues, or say if they have CAM or FAI, which is femoral acetabular impingement, they basically have a lower ceiling where their hips allow them to squat. So if I see an athlete with FAI and CAM and labral issues, I tend to get them to go single leg where possible, and not ask the grass squatting, full squats. It's just gonna inevitably, you want to remove the excess loading on it. So if their sport like golf is going to put enough on it, then I wouldn't be adding any extra loading on in the gym settings.